Hello, my name is Victoria Morales, and I'm doing a presentation on the relationship between simulation in nursing education and medication safety. In 2005, Ontario, Canada was the first large area in North America to mandate BSN in nursing registration. Simulation labs were created to meet the clinical placement needs of nursing students due to the decreased amount of clinical areas for students to practice med administration. The problem in the research paper that was focused on was the link between the decreased clinical placement time in BSN educational program and the students' ability to perform skills safely. Two causes that came out of it were inexperience and distraction. There was also lack of self-confidence and lack of knowledge. The research question within this research paper was, does the use of a simulation by second-year BSN students in med-surg and maternal child placement environments influence the student's ability to safely administer meds? The test hypothesis in this research was the simulation lab experience would increase the student's ability to safely administer meds in the clinical area. The research in this paper was a randomized control study with a post-test design only. There were 54 volunteer students. Of the 54, 24 were randomly placed in an experimental group. 30 were randomly placed into a control group. The volunteer list became the sampling frame of the research. The sample size was affected by a few factors. Students' fear of failing clinicals due to the fact that they were not familiar with simulation deterred some students from signing up to volunteer. There was a decreased amount of placement opportunities for these students. There were scheduling conflicts and student requests, which also factored into the sample size as some students switched out during the research. The independent variable of this study was the simulation lab. The dependent variable were the incident reports on safety or errors. The intervention for this research was to replace clinical hours with simulation lab hours. The ethics approval was done by the Research Ethics Boards of Canada, which is equivalent to the IRB here in the US. The data collection instrument was developed by one of the authors, Kimberly Sears. It was adapted from a survey that she created. The data was collected by clinical instructors, which included med errors and violation of the 5 rights. The data included the incident, the unit, and the instructor's name. Anything regarding the student was not submitted due to privacy guaranteed to the students that volunteered. The Likert scale was used, and contributing factors were found to be distraction, lack of self-confidence, lack of knowledge, and lack of experience. The incidents that were reported were analyzed using the SPSS version 13 software. The simulation itself was done by taking the group of volunteers and putting them into groups of 5. When they came in, they got report on a patient and had 1 hour to prepare. After they were done preparing, they came to assess the patient, perform any interventions needed, and do med administration. When they were done with that, they would debrief at the bedside and talk about what went well, what went wrong, what they forgot, what they didn't know. Then they came back and repeated the simulation with their improved knowledge and an increase in their confidence. The results were that the control group had more errors. They had a total of 24. The experimental group, which was the simulation group, had fewer errors and only had 7 compared to the control group, which had 24, which was a significant difference. The predicted outcome for this research was proven. There were limitations to this research. 2 hospitals were used. One hospital had a better med system. They used unit dosing, and the med system was computer friendly to the students, which may have contributed to less errors. The 2 groups came from one nursing program, which means that the results cannot be generalized to all nursing programs. What also came out was that more BSNs in a unit, on a floor, in a facility, in the hospital, equals better patient outcomes. It also shows that simulation education labs develop competency and more self-confidence in the student nurses. The conclusion is that the simulation education reduces med errors in novice nurses. Although the study should be replicated with a larger sample group and using more nursing programs, it does prove that the simulation does help prevent med errors, and it increases patient outcome in the clinical area. Thank you.